have a comprehensive, full-range surgical program. With that, we offer multiple procedures, including gastric bypass, adjustable gastric band, and gastric sleeve. Our program is patient-centered in the sense that we want patients to be involved in the process from the beginning. We want patients to be involved in the information prior to surgery, with the expectation that they would gather an understanding of what the surgeries are and how they work so that we can put the right surgery with the right patient. The question is, what causes obesity? Multiple things cause obesity. Obesity is an independent risk factor or aggravating agent for 30 common health conditions. Our goal is to put these 30 common health conditions back into remission.
We've seen from 1990 to 2010, literally a doubling of the percent of Americans who are obese, from about 15% roughly nationwide in 1990 to 30% and greater in 2010. Currently, a lot of the states, especially in the South, have percentages of people who are obese that are approaching 40%, and in some cases even greater than that. And the problem with that, from a health standpoint, is the health problems that go hand in hand with obesity, what are called the obesity-associated comorbidities. A medical phrase that means, again, medical problems that are a direct consequence of obesity. So you see problems like heart disease, high cholesterol, diabetes, degenerative joint disease, sleep apnea, urinary incontinence in women, reflux. A number of cancers have markedly higher percentages of people developing cancers who are obese than non-obese. And the list frankly goes on and on. Liver disease, lung disease, there's few systems that aren't affected by a patient's obesity. So when we as a country have twice as many obese people as we had 20 years ago, you can see the effect on our nation's overall health.
What causes obesity? Why does one person have a weight loss problem and other people don't? We certainly see a genetic predisposition. We know that weight loss problems and weight problems do run in families. There's also a physiologic reason. What that means is there's changes within the body that a person who has weight problems experiences. As an example, there's hormones, leptin and ghrelin. Specifically, the hormone ghrelin is produced in the fundus of the stomach, and that hormone signals to the brain that you're hungry. It's a very powerful hormone that drives a person to eat more. These issues certainly play a role in why we see obesity in populations.
Well, there's not just a single cause of obesity, it's multifactorial. Certainly your genes that you inherit from your parents have a lot to do with it. You know, we see families for lots of healthcare issues that the whole family's large, and other families where the whole family, everybody's skinny. So certainly there is a genetic predisposition to it. I think they've identified a few genes that are associated with being overweight. They're hard to document, they're hard to measure in people, they're expensive. You know, they say that there's probably about 50 different genes that are associated with being overweight. So it certainly is one of the causes.
Measuring obesity. How do we put one person versus another person, whether they're 4 foot tall or 6 foot tall, in the same playing ground? What we use is the BMI, or body mass index. What that is the ratio of kilograms per meter squared. This allows us to take a look and measure short versus tall people and then get an idea of what we expect in terms of weight loss, both pre- and post-surgery. When you look at degrees of obesity, our target audience is clear. The BMI of 35 and above, or even a BMI of 30 and above, as most recent data shows. Bariatric surgery or metabolic surgery certainly makes a huge difference in that patient population. Obesity is certainly an epidemic, and what we see is 3 out of 5 Americans are overweight or even obese. In the past 20 years, this has doubled. This obesity counts for 300,000 premature deaths per year.
So degrees of obesity are based on measurements of our height and weight, which we use to calculate body mass index. Body mass index is commonly called or referred to as BMI. And there's categories. The normal range of body mass index is between 20 and 25. Then as we get with higher weights, there's overweight, which is 25 to 30. There's obese, which is 30 to 35, severe obesity, which is 35 to 40, and morbid obesity, which is over 40. By and large, what we're concerned about is, as far as surgical correction of obesity, we're looking at people who have a BMI of 35 and greater.
When you look at trends in the United States, when you look at specifically Texas back in 1987, you can see that 10 to 14% of the population has a BMI of greater than 30. As we advance forward, you can see that in 2001, we've jumped to 20 and 24% of the population. 2005, greater than 25%. In 2010, what we notice is greater than 30% of the population has a BMI greater than 30. What's the risk? What we see is when a person's BMI is above 30, we see a big risk of heart problems or coronary artery disease or heart attack or any kind of heart issue. In addition, we see increases in stroke, and then the big one is a 400% increase in type 2 diabetes. These are all reasons why it's important that we focus on weight loss, as well as the metabolic issues to resolve these medical problems. The one that consistently leads the top of the list are diabetes or high blood sugars and hypertension or high blood pressures. We see high blood sugars, high blood pressures, and weight problems in a large portion of our population. In addition, there's a lot of medical disorders that you see that are usually along with those three primary problems. These are all things that we try to improve or resolve with weight loss and surgical metabolic bariatric surgery. Treating obesity. There's lots of ways to attack and treat obesity. They're all important and they all have a role. When you look at diet and exercise, it's certainly important. As a matter of fact, you need to have diet and exercise along with surgery to have a truly successful program. Diet and exercise alone can typically not cause the weight loss that's desired or needed. These metabolic surgeries are very good at making a person feel full. When you look at diet and exercise and a behavioral change program, when you look at those that exist all by themselves that are not associated with surgery, we see a 10% weight loss as an ineffective program, and long-term failure rates are pretty high. Again, that's because we need a negative feedback or the sensation of being full to truly be as successful as we're looking for.
Well, the impact is expanding. When I first started doing this over 10 years ago, I got all my patients word of mouth. Then they would go back to their primary care physicians and they'd see remarkable change in their health. They'd see their blood pressure go down. They'd see their diabetes. They've been working with these people for years and haven't been able to get the results that we are with the weight loss surgery.
When you look at medications for weight loss, they're typically not powerful enough, or there's multiple side effects that are associated with them. Initially, bariatric surgery was done through a big incision. This incision caused pain and problems. It's now down to laparoscopically, and laparoscopically or minimally invasive surgery has certainly changed the game from a bariatric surgery standpoint.
One of the great benefits of doing laparoscopic surgery is that when you work through little small incisions, the patients have much less pain, much fewer incisional problems, a dramatic decrease in any problems with wound infections, with hernias. It is because of that minimal amount of pain that they have such a quick recovery, why they're comfortable going home the day after surgery, why a lot of our patients go back to work in less than a week after surgery, in spite of what is potentially a very big surgery on their stomach, that they feel well, that they're tolerating their diet, and they're functioning well.
The problem with exercise is to lose 1 pound, you've got to burn 3,500 calories. To lose 100 pounds, that's 350,000 calories. It becomes a numbers game. What we need to do is look for ways to burn calories, but also restrict those calories coming in. There are multiple types of surgeries that exist for obesity, and it's important to have a general understanding of what they do and why they work. This way, we can choose the right procedure for the right person.
Here at CHI, St. Joseph's Weight Loss Center, we have several bariatric options. We have the Roux-en-Y gastric bypass, the sleeve gastrectomy. We do offer the gastric band, all done laparoscopically.
The first one is malabsorptive. What that means is it limits what can actually get from the intestines into the body. The procedure that's listed under that is called a duodenal switch or a biliopancreatic diversion with or without duodenal switch. The next group of surgeries are restrictive procedures. With that, we have the VBG, the next one's the adjustable gastric band, and the last one's the gastric sleeve. Then we have a combination of the malabsorptive and restrictive procedures, and that's the Roux-en-Y gastric bypass. With that, we'll take a quick snapshot of what these surgeries look like from an anatomic standpoint. The first one I want to show you is traditional weight loss surgery. Big incision. It came at a cost in terms of pain, hernias, and wound infections. Now we do these operations laparoscopically through these small incisions, and this really changed what we do. The most important thing is people like it. They can get up, they can move around, the pain's less, and faster recovery. It certainly has allowed bariatric or metabolic surgery to really flourish. You have a bit of food that comes through the mouth into the esophagus and into the stomach. The stomach is a very wonderful organ at accommodating what you give it. Then it flows into the small intestines where digestion actually occurs. The pancreas and the liver provide enzymes that break the food down, and it occurs in the small intestine. With that, we'll take a look at what these surgeries actually do. The first one's a VBG, or vertical banded gastroplasty. This surgery has typically fallen out of favor in most places throughout the country. The esophagus comes down, a hole is punched in the stomach, and a band is placed there. In addition, there's a staple line fired. This surgery didn't work for a variety of reasons. One of them is the staple line would just open up all by itself. The second thing is this band was not adjustable. We certainly can do better with the surgical options that exist now. The next one is a biliopancreatic diversion. This operation is pretty interesting. The stomach is turned into a tube, the duodenum is cut, and then the small intestines are cut as well, and everything's put back together. As you eat a bite of food, it sits in a stomach that cannot hold very much, and then the food falls into the intestines here. The pancreas and the liver get their enzymes, and it follows this pathway, and they all meet up at the very end of the small intestines. The next one we want to talk about is the gastric sleeve. With this operation, what happens is a spacer is placed into the stomach and then a sleeve is created. What that means is the stomach is cut, stapled, and this part of the stomach is removed. It turns out this part of the stomach is responsible for the majority of that hormone that's produced called ghrelin. Remember, ghrelin is a hormone that signals the body or the brain that there's hunger. We get a nice hormonal response with this operation, as well as a restrictive response. A large portion of the stomach is removed. It's done laparoscopically, and it takes about an hour and a half to 2 hours. Advantages of gastric sleeve: no rerouting, no need for adjustments, earlier results are certainly better than lap band, and it has a low operative complication rate. The next operation is the Roux-en-Y gastric bypass. What happens with this operation is the esophagus comes down and a pouch is created at the top part of the stomach. This pouch is about the size of a hard-boiled egg. Then the intestines are plugged into the pouch and then replugged back into themselves. That's how this operation works. You bypass this portion of the intestinal tract and you have a small pouch that fills full quickly to give that sensation of being full. This operation takes about 2 to 3 hours to do, and return to work on average is about 2 weeks. With the gastric bypass, we see rapid weight loss, typically more weight loss than the other operations. The disadvantages with the gastric bypass is cutting, stapling, and rerouting. When you cut, staple, and reroute, this increases the risk of the operation. In addition, we see dumping syndrome. Dumping syndrome can occur when you reroute the intestines as well. This is a syndrome where abdominal pain, maybe some flushing, and even some diarrhea can occur. We'll move on to the next operation, which is the adjustable gastric band, or the lap band. The band is placed at the same part of the stomach, and it's connected to a tube which is connected to a port. It takes about an hour to do. The band and the port are all contained in the body. Nothing hangs out of the body. Once the operation's done, the vast majority of the people go home the same day of the operation. The band has a nice cushion that we use to increase or decrease the size around the stomach to give that sensation of being full. The adjustable gastric band is nice because it can be customized per patient. There's less risk because we don't have to cut or staple. The band goes in, so therefore it can come out, and we call that removable. The main disadvantage is slower weight loss than gastric bypass. When you look at postoperative care or care after surgery, pain medications or anti-inflammatories are okay in moderation. In addition, we use sutures or superglue, or most of the time, just regular old Band-Aids on the skin. We want people up and walking and moving after surgery. We like to check the anatomy depending on the operation to make sure that the surgery continues to look the way it did during the operation. The diet after surgery is pretty intense, clear liquids to full liquids to purees. Everybody will see a nutritionist that specializes in bariatric surgery to go over the diet after surgery in more detail.
We have a bariatric coordinator. We have a bariatric dietitian. We have special bariatric rooms both in the operating room and on the surgical floor. We put together a program of excellence because we knew that this procedure, unlike a lot of the general surgical procedures that we perform, is special. It's unique and it requires special care, special thought, special training, both in the physicians and the staff in the hospital that works with the patients, to be able to perform this not just well, but with excellence.
When you look at complications per procedure, here's a few that we see based on the operation. The gastric band can sometimes slip, or the pouch above the band can enlarge. The band can erode or rub a hole in the stomach. We see infections. With any operations, infections are always a risk, and we make sure that we address that. The next one's gastric sleeve. We see nausea and or reflux occur after the gastric sleeve, and these are things that we investigate prior to surgery. In addition, when you cut and staple, as done with the gastric sleeve, that staple line has the ability to not heal properly. If that happens, that's called a gastric leak. There are ways to check this, both intraoperatively, meaning during the operation, as well as an X-ray after the operation. The last one is complications of gastric bypass. Sometimes we see intestinal leakage, certainly something that we want to watch out for. We can see obstruction of the intestines, and we can see dumping syndrome, as we mentioned earlier. The other thing we see with gastric bypass because of the rerouting is late complications. Internal hernias can occur. Stitches at the intestines are put back together, and even deficiencies from iron, B12, and calcium. It's important to understand this, and again, everybody sees a dedicated nutritionist to learn how to combat these issues if they occur.
There are a number of problems that are inherent to any abdominal surgery, things like developing a pneumonia, developing blood clots in your legs, things that we go out of our way to take care of to prevent on all of our patients that we operate on, including, of course, our bariatric surgery patients.
The effect on mortality. What's interesting with these operations is right out of the gates we see an 89% reduction of the risk of death within the first 5 years. It's a very strong metabolic response that occurs in these operations as the healing process continues and resolves. We see improvement or resolution of multiple medical problems, and here's the list: diabetes, hypertension, arthritis, sleep apnea, increased cholesterol or hyperlipids. We also see changes in fertility or menstrual cycles, as well as stress incontinence or even asthma. When you take a closer look at type 2 diabetes, we can see surgery has a wonderful improvement in type 2 diabetes. We look at this as a resolution based on who can come off their medications.
I chose this specialty because I have the happiest patients of anything I do after weight loss surgery. I can save lives. I can be in the trauma center, and patients are they're to some degree grateful that you saved their life. But when you change a life through this surgery, it's like nothing else that you can do for someone. They are very, very excited and happy people.
What's important to do as you go through this process is figure out which operation is right for you. It's important to look at the risks or the mortality versus the success or the weight loss. It's important to look at this and continue to investigate and choose the right operation for the right person. All of these operations work slightly differently, and they all have different levels of success with different levels of risks.
I was about 260 pounds. I had just been diagnosed as pre-diabetic, which was really frightening for me because I was barely 50 years old. And that whole diabetes thing at 50 years old is like, no, I don't want to do that. I had the surgery in May of 2013, and by December of that year, I'd lost 60 pounds.
To meet the criteria for surgery, you have to have a BMI above 40 or a BMI above 35 with any kind of combination of medical issues, age 18 or above, and a history of weight problems. It's important that a person attempt weight loss as well. Having these operations and never having had a diet attempt before is probably not the right thing to do. It's important to understand that diet and exercise have to come along with weight loss surgery. Not everyone's a candidate and requires medical screening. We have psychological screening performed and require your past surgical history. If somebody had surgery on their abdominal cavity or their abdomen, then it could certainly dictate which operation we do or possibly remove a person from consideration altogether. Surgery is clearly successful, but nothing's perfect. It's important to have the right person with the right operation. Occasionally, surgery needs to be revised or reversed, and it's important to know that going into this process. Despite this, the overwhelming majority of people are happy and healthy after surgery.
I wish that I had done the surgery much sooner in my life. I feel like there's probably 10 years of my life that I could have lived more fully had I had the surgery sooner rather than later. But having said that, I'm certainly making the most of what I've got now. We go and do a lot, and I can't imagine being that woman that had no energy and was always tired and was on all that medicine anymore. That just, I wouldn't want to go back to that.